I'm sorry, is that like the most 2020 thing you can say? Can you hear me okay? And your mute is on. I think those are the two lines we've all probably said the most over the last couple of years. So I just wanted to say, first of all, good morning, everyone. I'm Dave Coulter. I'm the Oakland County Executive, and I want to welcome you all to what I think is a really important community discussion on suicide prevention in a virtual world. And I guess it's very appropriate that we're doing this virtually this morning. I will just share with you that this subject has a personal resonance for me. When I was younger, I lost my best friend to suicide. And so efforts to prevent anyone else from going through that kind of despair and belief that there's no other way to stop their pain are critically important to me and personal as well. So as you all know, COVID-19 has in many ways altered our daily lives nearly overnight. We began working remotely, and for many that meant isolation and loss of their support networks and human contacts, which is so critical. It also changed the way mental health and suicide prevention services were delivered. But I have to say, I think our providers quickly adapted as the demand for these services, not surprisingly, increased. So we did things, you all did things like developing and putting in new telehealth services into a broader use than had done before, putting the safety protocols in place for your in-person services. And I guess I would say, creating virtual offerings through webinars and groups and special events to support mental health. And all of these things I think have been really important. So while the pandemic has been really devastating for a lot of Oakland County families and Michigan, frankly, there is one piece of slightly good news, and that is that we didn't see a dramatic increase in suicide deaths during the pandemic. And I think that's a testament to a lot of the work that you all do. But what we have seen is a dramatic jump in reports of depression and PTSD and anxiety, which means we have to do more to increase access to mental health services to all of our residents, right? And that's why, as a county, by the way, we've committed $12 million from our federal American Rescue Plan funds that we've received into two really, I think, vital programs that'll help achieve that goal. First, we're partnering with the United Way of Southeast Michigan to administer $10 million in mental health and behavioral services grants to nonprofits across the county. United Way was a great partner of ours last year, and they're going to partner again with us to review the applications, and we're going to begin awarding that funding next month. We're also working with the Michigan Hospital Association to provide better and quicker access to psychiatric mental health in our hospital emergency rooms, where we know we've seen a dramatic spike. These programs hopefully can help provide the services for a return to in-person visits. But I think many of you and many of the providers I'm talking to fully expect that virtual visits will, at least in some form, remain for the foreseeable future. But one thing is clear, the virtual remote world is here to stay for so many things, including access to mental health services. And so today, you're going to hear from mental health providers from a variety of sectors, from community mental health to schools, and both inpatient and outpatient service providers. And during today's sessions that I'm so glad you were able to join. And by the way, is brought to you by Oakland County's Suicide Prevention Task Force. You're going to hear how they've adapted to this new remote reality during COVID, the challenges they faced, and the lessons they've learned that have enabled them to continue to provide safe and effective services. I just want you to know that at Oakland County, we regularly track the number of suicide deaths and attempts, as well as the number of people who are seeking mental health services at the national, state, and local level, so that we can continue to better meet the mental health needs of people in this community. So I just wanted to jump on and encourage this work. Thank you for joining. And now I'm going to turn it over to Kat Palmer, who is from our Oakland County Health Division, and she's going to lead us now into a conversation about a little bit more about the suicide prevention efforts taking place here in Oakland County. So have a great morning, everyone, and thanks for joining.
Thank you so much, County Executive Coulter. I'm going to remove the spotlight from you real quick.
Thank you.
actually, Christine, would you remove the spotlight if you can and spotlight me? I'm on two
Yes.
devices right now. Again, a very 2020 thing. So yes, hello. My name is Kat Palmier. I'm a health educator with Oakland County Health Division, and I facilitate the Oakland County Suicide Prevention Task Force. I'm also a therapist myself and have my own private practice, so I know firsthand the experience of having to adapt and go virtual as soon as the pandemic began. It was quite the experience. Before we begin, I want to go over a few housekeeping items. And one of them is that I know that the topic of suicide can be quite personal for many of us. So I just encourage you all to continue to check in with yourself, especially if this is a more personal topic to you, so that you know, if you need to take a break, if you need to do what you need to do to take care of yourself, you know, we totally support that. And if you need any extra support, this meeting is full of clinicians, so feel free to reach out to me, and then I can definitely point you in the right direction of somebody who might be able to offer some support. Another thing is we will not have a formal break today during our presentation, so I just also encourage you to do what you need to do to take care of yourself. So this meeting is being recorded. If you feel like you missed anything, you'll have the opportunity to go back and watch that. We're going to send this out to all participants as well. There will be 5 minutes of Q&A after each speaker. So we ask that you hold your questions until then. And if you would like to ask a question, you can do so in one of two ways. You can write it in the chat bar, and we will have somebody monitoring the chat, or you can unmute yourself and ask the question. For those that are on just their phones, in order to unmute yourself, you will have to do *6, and you can go ahead and unmute yourself and ask that question. Okay, I'd also like to introduce some members of the task force leadership board that are on here today. One is Christine Burke from Oakland Community Health Network. There's also Michelle Charmilano from Havenwick Hospital and Erica Saum from Farmington Public Schools. Each have played a very integral role in the task force itself and the planning of this event. So many thanks to them as well. So before as I dive into my part of the presentation, we want to get to know you all a little bit. We have a couple of poll questions that we are going to ask. So for those who are on a device where you can access the polls, please do so. The first poll we want to ask you is, we want to know what represents you in terms of what role you might be, whether that is, are you a parent or a caregiver? Are you a community member? Are you a mental health care worker? Do you work in education, healthcare? So let us know who you are, and just so we can get an idea of who's here today. Give you a few seconds for that. I know these categories are not comprehensive by any means, but you know, I think this covers a lot of the people that typically attend our event, and if this is not you, then feel free to just select community member.
I have a question. I'm on the audio. Can you hear me?
Yeah, we can hear you. Who is speaking?
I see a couple people putting in the chat that they.
This is Dora.
Answers.
I wondered how we got I can't find in my email where I can link up to the actual visual normal meeting link. Is there any way to access that?
It is on
Suzanne, I'm not sure if you're able to show those results.
It's on the flyer, Dora.
Okay. I didn't.
And it's on our website. It's on our website. So if you go to www.oaklandchn.org, we have a calendar,
Okay,
public
looks like
calendar.
we have a lot of behavioral health care providers in today. We're still
I'm
getting
trying. I'll
some
do that.
results
Thank you.
in, community members, educators, a few parents. So thank you so much for that. And then I'm going to ask you all, I'm having some orientation issues here. Then I'm going to ask you all to share sort of share your why in the chat. So what brings you to this event today? Was it just a topic that interested you? Was it something maybe you're personally drawn to because of your own experience? Are you working in this field and want to know how other people have adapted to virtual mental health services? So let us know that as well. So go ahead and write that in the chat. I'll be calling some of those things out. Some people are here to learn more. They want to provide resources to the people they serve, understand how services have been adapted.
My name is Toriana.
You know, people who are worried about the people in their life, the people that they serve. Yeah, and just hearing a lot about wanting to learn more, hear about resources in Oakland County, of which we have many. Yeah, great.
Hello.
Keep those results
So my name is Toriana. I'm just on the call in, but I
Okay.
did want to introduce myself and say I'm from Cody
So I
Ridge.
am going to, while those results, I just got a question if I can hear people speaking. I cannot hear people speaking at this time. Thanks for that, Suzanne. So let's keep any comments to the chat, and we'll have an opportunity to unmute at the end. Okay, or at the end of my presentation. So I'm going to move on just for the sake of time here into the state of suicide prevention in Oakland County. So as I said, I do facilitate the Oakland County Suicide Prevention Task Force. And we are able to gather data on the local level, but also wanted to share this graphic from the American Foundation of Suicide Prevention. I will be sending this out afterwards, so you'll have access to this. But this is just the latest data we have at the state level from the CDC. So this is up to date through 2019. So if anybody knows anything about data, they tend to be about 1.5 to 2 years behind in terms of gathering the data and putting it all together and releasing it. So we are currently looking at a complete data set for 2019. But I do want to share what we have for Oakland County specifically. So I know everybody's wondering, have we seen more suicides as a result of the COVID-19 pandemic? And as County Executive Coulter said, we have not seen an increase. Our suicide deaths in 2020 were about on par with what we've seen in the past. And similarly, where we're at as of the end of August in 2021, we are also about on par. However, what we know about suicide death statistics is that that's just the tip of the iceberg. The bigger picture is underneath that tip of the iceberg is also suicide attempts, people who have thoughts of suicide, or people just struggling in general. So we don't want to just focus on suicide deaths. We want to also consider the fact that there are a lot of people still struggling to cope and adapt as a result of the pandemic, and many other factors. Our partner organizations are going to get into that today in terms of what they've seen, how people have been seeking services at an increased rate. So with the task force, we are so lucky to have a number of wonderful organizations in Oakland County who are really invested in suicide prevention. The ones listed here are just a few. And I work with all sorts of suicide prevention organizations around the state. And we do have a very robust mental health system in Oakland County. That includes our public mental health system, so Oakland Community Health Network, our specific crisis services that are under that umbrella of Oakland Community Health Network as well, but the Common Ground Resource and Crisis Center. And we have a multitude of private mental health providers as well. So the task force itself works on a number of initiatives. I wanted to give an example of some of the things that we are currently working towards. We want to create some resources that make it easier for people to access mental health services and understand how to navigate our mental health system. And then we're also working on a lethal means reduction campaign. So that is focused on the means somebody might use to attempt or die by suicide. So a lot of that focuses on firearms and working with firearm owners on our shared goal of wanting to reduce suicides by firearm. Creating a social media kit, a toolkit, as we continue to just want to raise awareness among our community so that all of our task force members can be disseminating information to our communities through their various social media channels. We want to keep our task force website up to date. That is oakgov.com/suicide prevention. I encourage you all to visit that. And then also create an upstream suicide prevention plan for the county. That is upstream suicide prevention, meaning there are a lot of things that might lead somebody to having thoughts of suicide. So what can we do as a community to decrease those risk factors and increase those protective factors? So we want to consider our role in that as a task force as well. This is just an example of a lethal means reduction campaign we did in the past called Make Your Home Suicide Safer. And just encouraging people to look at the access to lethal means in their home, be that medication, firearms, and just making their home a supportive and validating environment for anybody who might be going through a mental health crisis. We also provide a variety of evidence-based and research-informed suicide prevention training. You can see that on our website. But I thought I'd end with a little note of hope. Because we've been offering suicide prevention trainings for the past 6 years or so, we've trained over 4,000 people in Oakland County in a variety of different suicide prevention trainings. And these are some of the success stories. So I'm just going to share a few. One from our Safe Talk training in June 2018 said, I was able to readily identify potential signs of suicide in a high school student I work with. I intervened quickly and got the student the support they needed immediately, which is really powerful. And then from our Assist training in February 2018, I was contacted by a family member of a youth threatening suicide and connected them to Common Ground. The young man has since been to therapy and seems to be doing well. And lastly, in our Safe Talk in August 2017, based on the training I received, I was able to recognize key words in a student's conversation that were very alarming. Words and phrases that before the training I might not have recognized as alarming. So really, there's so much hope when it comes to suicide prevention. Who knows even what little seeds we're planting all the time. So I just want to encourage you all as we continue to hear maybe about some of the struggles that our community might be going through, that there is hope and that there's still so much that we can do to help those struggling and to prevent suicide. So for the sake of time, I'm going to hold off on question and answer for me. So if you have a question and answer or question specific to me in the presentation I just gave, please put that in the chat and I will be answering that as we go along. So that we can keep on target here. And then we might have time at the end for just overall question and answers, but I will try to answer your questions in the chat while we move on to our next presenters. That is Okay.
Okay.
So we are going to move on to hear from our community mental health organization. We have a variety of speakers from our community mental health to talk about the various services they provide and how they've adapted. So please give it up for, let me move forward. There we go.
Good morning.
All right, I'll have you get started. Thanks.
Good morning, and thank you, Kate. I am Dana Lassenby. I'm the CEO and president of Oakland Community Health Network. Oakland Community Health Network is the public behavioral health system that supports individuals in need of mental health services in Oakland County. We can move it to the next slide, please. About Oakland Community Health Network, we're the community-based local public mental health system that manages the specialty behavioral health services and supports in Oakland County for persons, particularly with children with serious emotional disturbances, individuals in need of crisis care and support, individuals with intellectual and/or developmental disabilities, infant mental health, serious mental illness, and substance use disorder. Most people who receive services from Oakland Community Health Network are on the public mental health system. In the public mental health system, receive Medicaid or are Medicaid eligible. So insurance and funding is not a barrier to receiving care and services. And I can't say that enough. We're a system where there is no wrong door. So at any point or any service delivery area, you can enter into the public mental health system and receive support and services from information and referral up into actually receiving hospitalization and residential services, which are some of the higher levels of care. Next slide, please. I want to stop here for a moment. And first of all, I really want to thank County Exec David Coulter and his team, as well as the Board of Commissioners. They have really put public mental health and mental health overall at the table and made it a priority for this community. And so without their support, some of the programs and services that we're looking to expand and that we already offer would not be possible. So I want to thank them for that. Most importantly, I want to thank the people who serve this community and the people who reach out and receive our services. Our mission is really to inspire hope, empower people, and strengthen our communities. And the only way to really do that is for us to work together and support one another and support the people who are the most vulnerable citizens in our community in need of help and services. I also wanted to make a point of also saying that part of our strategic plan and our priorities at Oakland Community Health Network really do align with what the state's direction is. Also very much in alignment and on the same page as what Oakland County is doing for mental health and the people of this community. So with that, our priorities are to improve access and make sure people know how to get the help of services that they really need. Also to expand our crisis services. The other priorities that we're looking at include extending integrated behavioral health care with physical health care, and we do that naturally in the public mental health system. The other part has to do with ensuring that we offer a comprehensive system of care for children in need. So we're not just looking at their mental health service needs, we're also looking at the other service and programs like school, education, working with their primary care, their pediatrician, to ensure all their service needs are being met in a holistic way. And finally, we are really promoting the behavioral health workforce. The mental health workforce are the essential workers that have really stepped up and stepped in to provide the support many need during the last 2 years, but even beyond that and before that, the direct care workers have been essential to ensuring that people have ongoing services and supports in the community. Next slide, please. So with that said, I have to thank our contracted network providers. Within Oakland Community Health Network, we have 180 service providers and more than 300 service sites throughout Oakland County. So often people associate our work with Common Ground, who is our crisis vendor, and our other core providers who you'll hear from today. Next slide, please. And so our non-emergency access or central screening for Oakland County is the number here, 248-464-6363. And so we offer walk-ins. We also offer telephonic access and screening for services. So in person, the address is listed there, and it is also on the county campus in Pontiac. But again, as I said, if you reach out to us to that number, there's no wrong door. You can actually go to any one of our providers and request support and services that are needed. Next slide, please. I just wanted to briefly highlight our Oakland County Youth Mobile Crisis Team. I know there is someone from Common Ground that is going to expand on the crisis services, but just to highlight what we're doing for youth. The Youth Mobile Crisis Team is available to children, teens, and young adults 0 to 21 years of age experiencing a mental health crisis. These services are provided by New Oakland Family Center. Youth Mobile Crisis includes a rapid response by mental health professionals who come to the location in Oakland County, on-spot counseling and crisis intervention, assessment and coordination and stabilization and ongoing services. So the number there listed on the slide is available for anyone who wants to reach out and ask for those type of services. The other things I just wanted to highlight really quickly before I turn it over, you know, we're working quite a bit with Oakland County's Executive's Office, and we're really proud to be able to offer some extended crisis services and supports through our work with the local law enforcement, with crisis intervention training, as well as co-responder programs, which has started off really small, but with the support of the Oakland County Exec and his office and his team, we're going to be able to extend those services, and then also expanding the work that we're doing with the school and helping families navigate to get support for their young people. So with that, I will thank you, and I'm sure questions will come later. Thank you so much.
Okay, we are here to talk about crisis services. Or we can move on if they are not here yet.
I'm here.
Perfect.
Yep. Good morning, everyone. My name is Heidi Warrington, and I'm the Chief Nursing Officer of Common Ground. And I'd like to thank Dave Coulter for hosting us. Sorry. Okay. So I'm going to share with you a little bit about Common Ground and our history. So Common Ground is the product of a 1998 merger of two agencies. So Common Ground and the Sanctuary. So that had served Oakland County since the early 1970s. So the merger allowed those in the community experiencing a crisis a single source for help. The unified approach to meeting community needs enabled both organizations to expand their services significantly. Common Ground was founded. I apologize. Okay. So Common Ground was founded in 1971 by a group of students, parents, and community leaders who were concerned about an increase in substance abuse and suicide among young people. United Community Service volunteers began the Sanctuary, and in response to the growing number of runaway youth in Oakland County, the residential counseling program for runaway and homeless youth ages 10 to 17 opened in 1974. The program offered youth 2 weeks in which to resolve the conflicts that led them to leave home. Today, Common Ground is a 24-hour crisis service agency dedicated to helping youth, adults, and family in crisis. Through its crisis line and in person, Common Ground provides professional and compassionate services to more than 80,000 people a year. And we see more than 8,000 people here at the Resource and Crisis Center on the Oakland County campus. So today, Common Ground is a 24-hour crisis service agency dedicated to helping youths, adults, and families in crisis. Through our crisis line and in person, we provide professional and compassionate service to more than 80,000 people a year. Every member of our team is dedicated to a core purpose and guided by our core values. A little bit about our services. So we have a 24-hour resource and crisis helpline. Anyone can call, text, or chat and speak with our professionally trained staff and volunteers to receive helpful information and referrals to local services. We also offer walk-in assessment and crisis intervention services here in Pontiac on the Oakland County campus. Through a face-to-face assessment, we provide crisis intervention and stabilization for Oakland County residents 24 hours a day, 7 days a week. We also have a mobile crisis team. Our mobile crisis team provides treatment to those in immediate crisis and connects them to ongoing treatment. We also have a victim assistance program. Now, if you're a victim of a crime, we offer assistance to those seeking advocacy, counseling, and support 24 hours a day, again, 7 days a week. Here, again, at the Resource and Crisis Center, we also have a crisis residential unit. Now, this is a 16-bed unit. It's very special, and we actually call it the Retreat. It's a very nice facility, and I encourage anyone that would like to have a tour, we could facilitate that. So the crisis residential unit is a short-term alternative up to 14 days to inpatient psychiatric hospitalization for adults ready to actively participate in recovery-oriented treatment environment. Now, the Sanctuary is a 24-hour shelter for at-risk youth aged 10 to 17 that aims to reunite families through counseling, skill building, and respite. Now, we also have a graduated apartment program, which we call GAP. This provides supported, subsidized housing for homeless adults aged 18 to 24. Residents are also provided counseling and case managed services. Now, when support groups get back together, we also have a whole slew of support groups, including survivors of suicide loss. This is an open group that provides support for those who have lost a loved one to suicide, survivors of homicide, growth and healing, becoming a love and logic parent, legal clinics, domestic violence, and an Empower initiative. Now, these are regaining strength virtually, but we will hopefully regain those support groups live and in person. And that's a little bit about our programs. Does anybody have any questions?
Hi, Heidi. How are you? Thank you so much for that wonderful overview of Common Ground. We do have a couple questions. The first is, how has Common Ground shifted gears during the pandemic to offer virtual programming or crisis intervention?
Support groups have regained their magnitude, I guess, virtually. However, I'm very proud of Common Ground. We remained actually open, in-service, face-to-face assessments, and we never did go virtual. We remained open during the entire pandemic, and we were able to keep ourselves safe. We had plenty of PPE, thank you, Executive Coulter, and we remained services. The only thing that possibly went to something would be telephonic, conversations versus in person with the emergency rooms, but we adapted well. We maintained all of our services without an outbreak of COVID. Our staff and all of the patients that we serve, people that we serve, were all remaining safe through our screening process. So we modified through PPE and precautions, but we always remained open for face-to-face services.
Thank you so much.
Yep.
I have a comment also, or a question, excuse me. Do you have to be an Oakland County resident to access referral services? If someone from Livingston called, could you also get them started?
Yeah, they'll get referred to their appropriate services in their county, where we do provide care to Oakland County residents. However, anyone can call the crisis line at any time and we'll connect them to services.
Thank you so much. Did Common Ground see any changes in the number of people seeking crisis services during the pandemic?
Yeah, it was surprising. It was surprising that we had, our decrease in suicide. We weren't anticipating that. Was, interesting how those numbers washed out. And actually, we saw a slight reduction an overall, you'd think that it would be higher. You know, I'm not quite sure. We'll have to do some analysis later about that, but there was a slight reduction in people seeking services. I don't know if it was out of, because we were face to face, you know, out of fear of contracting the virus, but yeah.
Okay, thank you so much. I do have one more. It looks like Melissa Bowman from Common Ground did write that the crisis line saw a large influx of calls during this past 19 months. So wonderful. Great. Any other questions? Feel free to write them in the chat. Otherwise, we will begin to move on. Thank you so much.
Thank you. Thank you for having me.
Kat, I'm not sure if you can hear or see. I think Wendy is up next.
Hello, can you guys hear me?
I can hear you, Wendy. I'm gonna put you on the spotlight if that's okay.
That's fine, thank you. Just let me know when.
You can go ahead, Wendy.
Okay,
Yeah.
great. Good morning, everyone. I'm Wendy Standifer. I'm the Director of Behavioral Health Services for Easter Seals, Michigan. Thank you so much for having me here today. This is a great forum, so thank you so much. I'm here to talk about our SUD, our Substance Use Disorder Treatment Services. And it looks like I think Oakland Family Services is also going to talk a little bit. Is that accurate?
Nope, you were just going to talk to this slide.
Okay. So there's a couple things on there that are specific to them. That's why I wanted to make sure. So Easter Seals, Michigan actually has, we are celebrating our 100th anniversary. We provide behavioral health services and SUD services for adults and children across Michigan. We have 11 locations, but our largest locations are in Oakland County. And we actually provide behavioral health for adults and children in Oakland County and in Macomb County, and then we also provide SUD services in Oakland County and in Macomb County. Some of the SUD services that we've been providing for a while, but kind of pivoted during the pandemic, is we have medicated assisted treatment programming. We do withdrawal management. We have outpatient services, case management services, peer recovery services. At Easter Seals, we do both regular outpatient substance abuse treatment, and we also do intensive outpatient substance abuse treatment. We have the same philosophy. There's no wrong door. So even if someone comes to us, we're going to figure out what they need and what is the best service for them. We also, during the pandemic, never shut our doors. We have always been open and providing face-to-face services, but we did pivot quickly to also providing telehealth and remote services on our EHR platform. That was a secure platform for individuals to receive their med services through psychiatrists and nurse practitioners. They are receiving individual counseling and group counseling through telehealth, as well as all of our assessments. So they could come into the office if that was what they needed and that's what they wanted to work on. And especially for our medication assisted treatment program, if we were doing our introductions of the different medications that are going to help them with their substance abuse, they would come into the office, they would see the nurse, they may see the doctor, and then they might do a combination of seeing their therapist face to face or joining virtually. What I love about this is as we're moving forward, we've seen an increase of individuals that have actually been able to show for their appointments. Telehealth has allowed us to not worry about transportation issues, childcare issues. We even were able to receive quite a few grants in order for us to be able to get the technology to the individuals that we serve. So we were able to deploy 500 plus iPads with Wi-Fi capability that these individuals have been able to keep so that they can not only join our services for substance abuse treatment, but they could also connect virtually for their NA and AA meetings. They could connect to their doctor's appointments, their medical appointments, and those types of things. Case management, we've always done in the community as well as virtually. We've moved more to face-to-face right now, even if individuals, as it's been beautiful and outside, meeting with them in the community. And then our recovery coaches have gone into the homes as well as been able to connect virtually. We do have women's specialty programs for SUD support. These are for our moms that are pregnant. These are for moms that might have young children, and there is specialty programs that are working with the SUD for that. And then also there's recovery housing in our communities. There's different contracts that we're able to refer and get individuals hooked up so that they have housing as well as substance abuse treatment right on site. And then, of course, our residential providers are throughout the network. So for those individuals that needed intensive treatment, where they were on site for residential anywhere from 30, 60, or 90 days. And we've been able to continue to coordinate and maintain those services. East Seals, Michigan overall has seen a tremendous increase of individuals being serviced for us for both behavioral health and SUD. Prior to the pandemic, on average, we were servicing about 12,000 individuals. Since the pandemic, we on average are servicing about 15,000 individuals. Any questions? I know that's quick, but I think I only had 3 to 5 minutes.
Thank you so much. That was a wonderful overview of services. If anybody has any questions, feel free to put them in the chat. I do have a couple. What were some of the barriers to providing virtual services, and what were some of the benefits that you saw?
That's a great question. So I think the biggest barrier was a lot of the individuals that we work with don't have the technology. They might have had a cell phone or they might have had an iPad, but they didn't have an internet platform that was strong enough to support the technology. So that was one of the things that we saw in the very beginning, and that's when we definitely shifted and started applying for grants that we received to provide them with those technology. And that the internet, not only the Wi-Fi. So we've been able to do that, which was very beneficial. I think probably the biggest thing with beneficial is, again, the show rate. Individuals now have a really good choice. They can come into the office or they can join via telehealth. So we're not as before transportation was an issue. For those individuals that are working, they had to worry about getting off of work and getting to their appointments, and now they can just join remotely. Childcare has always been an issue. Now with the ability to do it from a telehealth standpoint, childcare is no longer a barrier. So we've been able to really shift, and even the hybrid. We'll have groups going on right now that we have the technology so that you can either come to the group in person or you can join via telehealth. And it's been a really wonderful experience for individuals that feel comfortable coming in, but they can, and then those that are remote, because nobody's missing those treatment. They can join together, and we've been able to install some new technology that allows us to have this blended hybrid model.
That's amazing. So I'm assuming it's safe to say that you will continue with this hybrid model moving forward?
Yes. We're looking at it from a lot of different areas. Obviously, as the state shifts and pivots in regards to certain things, but absolutely. We always offer face-to-face. With this population, we always offer face-to-face first and foremost, but then there's this option if they are not comfortable coming in or unable to come in. And like I said, a lot of the individuals that we're serving are doing a combination of both. Sometimes they come into the office, and then sometimes they'll do some of the telehealth. But yes, we will definitely be providing that in the future. I think I saw something about the demand. How did we address the demand of those individuals? We were very fortunate. We've been able to hire additional staff, and we've been able to staff accordingly to the volume that was coming in. So we've added case management positions, we've added therapy positions, we've added recovery coaches and peer support specialists.
Awesome. Thank you so much. One more question. Any information about the technology that you're using for the hybrid model? We would like to continue to offer virtual options for groups and coalition meetings, but are struggling a bit to figure out how to do that.
Yes, so we actually invested in an EHR virtual, well, it's not an EHR, it's a virtual telehealth platform. It's called eVisit, and it is a secure telehealth platform that we utilize for our appointments, whether those are med services or individual therapy. There is some group option on there, but it's a little bit limited. So we've utilized Teams and Zoom for that. As well, but we're constantly looking at different platforms to make sure confidentiality and then easy of use, right? The reason that we love the eVisit is it's just a link that gets sent that the individuals can just click and join.
Thank you so much.
All right. Well, thank you so much for having me. I appreciate everyone's time.
Thank you. Now we're going to hear a little bit of, I apologize, adult mental health services offered through TTI and CNS care. So both Lori and
Kat, I think your mic went out a little bit. So Lori Gell from TTI and Cheryl LaFleur from CNS. I think Lori is going to speak first.
All right, there we go. Good morning, everybody. My name is Lori Gell. I am with TTI. I am the education specialist, and I thank you guys for all being here. I, again, like several of the people before me, was given 3 to 5 minutes. So this is going to be a concise kind of overview about Zero Suicide specifically. TTI is a CMH provider. We offer numerous services, many of which are being talked about from multiple providers. We also have an outpatient clinic for individuals not needing the intensity of CMH services. We also provided services through the pandemic, whether it be face-to-face as needed and people's comfortability. And then we are also able to move into telehealth, doing the groups and therapy and other ancillary services. So that was wonderful to continue working with our people. Okay, so Zero Suicide is exactly what it sounds like. It's based on that premise that no suicide is okay. We want to get to the point that we have so many supports and services out there that people know where to get help, and we don't have any suicides completed throughout, hopefully, the world, but we're focusing on Oakland County right now. So we began to work with Oakland County on Zero Suicide a few years ago, and we've embedded this 100% into our daily work. We have several locations throughout multiple counties in Michigan, so this is across the board for TTI. It focuses on the need for ongoing assessment of our providers. We all know things change daily and treatments improve, and we need to be able to do that to provide the best services. So TTI did implement this process and has provided all of our staff the workforce survey to identify our strengths and our weaknesses so we can better prepare every year to provide good services. Another area includes the need to focus on ongoing education of staff and the community, so we increase awareness of the signs and symptoms and to be able to provide the best care possible, whether it's to individuals we work with at TTI or people we know or meet in the community. TTI has a training department, and we offer many trainings to the community, one of which is suicide awareness and prevention. I will be happy to throw our website link in the chat, but I encourage you to check it out. All of TTI employees are provided an orientation training related to suicide awareness prevention interventions. And then they're also required to maintain training every year. And when I say all employees, I mean all employees. So from our administration, support staff, finance department, to our clinicians and peer supports. Zero Suicide also emphasizes that suicide awareness and prevention is everyone's responsibility. We all need to be aware of signs and symptoms and be able to provide support to the best of our ability, which also includes knowing where to reach out for help. TTI's website offers many options for resources in the community and across Michigan. And again, I encourage you to check it out. We want to be a resource to Michigan as a whole, because sometimes we all need some support. Zero Suicide also emphasizes the need for increased services for individuals that just need extra services and help or are expressing suicidal ideation. Some of these can be an increase in case management, individual therapy, peer supports, ancillary services, groups, and then we focus a lot on our treatment team coordination, because the more we're on the same page, the more we can help people and support along the way. We work to meet the individual where they're at, because not everything works for everyone. So we want to be able to assess that and determine what level of care people need. We continue to work to improve our overall standard of care. And Zero Suicide just happens to be one of the ways we're doing this and continuing to coordinate. So that was my brief spiel that I was given 3 to 5 minutes. I think I made it. If you have any questions, I'm happy to answer those. Otherwise, thank you so much for your time.
I think Kat's having some sound trouble. I'm not sure, but I think Cheryl is up next. We're sharing this slide.
Yes, can you all hear me?
We can hear you, Cheryl.
Great, I had sound problems yesterday. Let me turn my camera on. Hi, everybody. I am from CNS Healthcare, and we recently merged with Northeast Integrated Care. And so we now have offices in Wayne County and all over Oakland County. And we provide, we're a certified community behavioral health care clinic. It's a big, long sentence. And we are able to provide services for children and older adults. And if a person has little or no insurance, we are able to see them. We were open throughout the pandemic as well. And we still have telehealth services ongoing, and we are open to see people face to face. We do have our medical care treatment, the nursing services, peer support, psychiatry, medication management. What I really want to talk about is the team that I work on. I work on the award-winning anti-stigma team, and we are people with a lived experience that go around and travel to different locations, and we do not charge for this. We do presentations to educate people on the stigma associated with mental health and substance use disorders. We were originally started in 2005 with a 1-year grant funded program and became a permanent part of CNS Healthcare. We are funded by Oakland County Health Network and Michigan Department of Health and Human Services. Actually, it was a blessing in disguise with our pandemic. We started meeting people virtually, and that has allowed us to meet people all over the country without having to travel. And we are ongoing, still doing educational services, and we actually put together a grief support presentation. So we're always updating and adding more presentations to our agenda, and whatever somebody wants us to talk about, we will tailor it to their needs. And again, like I said, we don't charge for those services. We do educate nursing students, psych students. We've gone to churches and within our organization. And that's a lot of stuff, but if anyone has any questions, I can provide information in the chat for phone number and contact information or anything like that.
I do not see any questions, Cheryl, but if you could include that information. We do have a resource document in there for all of our providers and presenters, but please feel free to add that information. I know Kat's still having some technical issues with her audio right now, but I appreciate you helping and being on with us today.
Thank you.
It's nice to see you, Cheryl.
Nice to see you too. I will put our anti-stigma contact information in the chat.
Okay, and then next I think we have Debbie Smith from Oakland Family Services. So I will spotlight you if that's okay.
Good morning, everybody. Can everybody hear me?
We can hear you.
Great. So good morning. Thanks for having me. I'm Debbie Smith from Oakland Family Services. I am the Director of Specialized Services for Youth here. So I'm going to talk about children with serious emotional disturbances and the services that both Easter Seals and Oakland Family Services provides for that population. So both agencies have locations all over Oakland County. We both provide both telehealth and face-to-face services. So we like to give families choices, whatever they're most comfortable with, whether that be in person or telehealth. So we both provide services to youth with severe emotional disturbances between the ages of 5 and 21. In addition, Easter Seals is able to provide services to the 0 to 6 population as well. You might be wondering what SED or serious emotional disturbances mean. It's really the more moderate to severe mental health issues in children, and these children are oftentimes at risk for hospitalization or placement in residential programs through the juvenile justice or foster care systems. Our goal is to keep these children in the community with their families. So common needs that we treat are related to depression, anxiety, trauma, ADHD, substance use, behavioral issues, problems in school, and family problems. So to get into these services, a family would call the Access Department of Oakland Community Health Network that was described earlier in this presentation. And after that screening, an intake would be scheduled with either Oakland Family Services or Easter Seals, that is the family's choice. The intake is a very comprehensive assessment of the youth and family's strengths and needs. And the intake clinician will make a recommendation about home-based or outpatient services based on those strengths and needs. So whether a family is eligible for or chooses outpatient or home-based, they will be assigned a therapist that will provide both individual and family therapy. Many therapists at both Easter Seals and Oakland Family Services are trained in evidence-based practices, and some of those are related to trauma and specialized parenting skills. Through person-centered planning, we can also provide a multitude of other services to these youth and families, including group therapy, psychiatric services, case management services, and integrated health through the behavioral health home model. We also have many different types of peers, including parent support partners who are parents that have children with lived experience in the mental health system. And we also have youth peer specialist supports who are young adults who also had lived experience as children with the mental health system. We can refer out for a lot of services, respite to give caregivers a break, community living supports to teach youth necessary skills in the community, applied behavioral analysis, for children on the autism spectrum, wraparound, and so many more services. Both Oakland Family Services and Easter Seals have 24/7 availability to a therapist to assist with any crisis needs All of our therapists are trained in screening for both self-harm and suicidal ideation, and can help families make the decision to have their child screened for hospitalization, either through Common Ground or the Youth Mobile Crisis Unit, or to keep the child at home safely. I'm going to answer a couple of questions that were asked about other agencies. So we did, during the pandemic, certainly see an increase in both suicide attempts and hospitalizations in our youth. So we know that the pandemic is having a huge impact on our children. And with school starting, we expect some more things to come up and more youth coming through our doors. Does anybody have any questions?
I do see one question, Debbie. It just says, are these services you are describing free?
So children with serious emotional disturbances, all of those services are for children that live in Oakland County with Medicaid. And in that case, all of those services are paid for through Medicaid and through Oakland Community Health Network.
That is all I see. Thank you, Debbie. I appreciate your help and work on this project over the last few weeks. So, and finally, from the OCHN network, but it's Marianne is going to join us. She's going to, from the Alliance of Coalitions for Healthy Communities, and she's going to talk about some of our substance use suicide prevention efforts. And I'm going to spotlight you, Marianne.
Okay, can you hear me?
Yes, we can hear you.
Okay, my name is Marianne Vergeth. I'm the Prevention Program Director for the Alliance of Coalitions for Healthy Communities. We've been doing prevention services throughout Oakland County for almost 20 years now. We were established back in 2003. Our mission is through substance abuse prevention, mental and physical wellness, and recovery support programs. The Alliance connects, strengthens, and mobilizes strategic partners to promote healthier communities. And our biggest, pride and large focus of our work is the support to a 22 prevention coalition network that blankets Oakland County. So pretty much every school district is serviced by a prevention coalition. We provide funding and technical assistance, resources, and services to help coalitions to be able to address their local needs when it comes to substance use prevention, primarily focused on youth, but we focus on the family as well. Another point of pride for us is our Narcan training that we do throughout Oakland County. We have seen an increase in overdoses since over last year with the pandemic. 2020, there was an increase over 2019 with the pandemic. So we're able to offer Narcan training. We moved it to a virtual platform during the pandemic. 2 days a week, we offer it standard. It can be accessed and you can register through our website. And then now we're actually going back out into the community and offering it in any community that requests it. We work a lot with our coalitions as well to get these Narcan trainings at the local level. And then we also do drive-through. So we've done a few drive-through trainings during the pandemic. Some highlights of our organization, like I said, we support 22 coalitions. We provide them with integrated prevention programs and services. We provide the opportunity for them to be able to network with each other and share ideas and resources. Some of the things the coalitions did as we had to move to a virtual platform is they offered a lot of programs and meetings virtually and trainings for their communities. And then we really utilized a lot of social media to get prevention messaging out there. The Alliance during the pandemic, we were able to pivot quickly and provide a lot of our services online. I already mentioned the Narcan training. We also have Shatter the Stigma support groups for individuals who are in recovery or families, loved ones of individuals in recovery. So we offer those Shatter the Stigma support meetings twice a week virtually. We also have some specific programs that we offer to young people. One of them is Keep Them Safe, Keep Them Healthy, which is, and again, this is, we used to always go into the schools with this program, and we started doing it virtually during the pandemic. This is a program where we have a person who's in long-term recovery comes in and talks about their recovery journey. We do pre-post on this program, and we always see an increase in perception of risk once these young people participate in this presentation. So we get really good outcomes with this program. The other one that we're seeing an increase in, especially with the mental health issues that young people are facing as a result of the pandemic, is Renewed. And that is a 4-session program where we focus on anxiety, stress, and depression, providing tools for young people. It's got a mindfulness base. So we teach them some mindful moving, some breathing techniques, how to recognize some of their uncomfortable feelings, how to cope with them. And then we also get into how to recognize healthy and unhealthy friendships, as well as social media mindfulness. So this is offered to middle school students, and we offer it virtually. However, this year, again, all of our programs that have been virtual for the last year and a half, we are offering them in person, provided that the right COVID protocols are in place. We also have a program for individuals in early recovery that's called Resolve. That, again, has been moved to a virtual platform. And then we're also modifying it and offering it to students who are in alternative high school setting. And this, again, it's a life skills training. It provides just some tools for people in early recovery to help them to be able to maintain their recovery and kind of deal with some of their feelings and prevent them from, hopefully, any kind of relapse. We also are the SINAR, Designated Youth Tobacco Representative for Oakland County, and so we do all the tobacco checks, retailer education visits, and tobacco checks. We do alcohol retailer education visits. We provide wellness services. We have what's called World of Wellness Wednesdays. So every Wednesday we upload a video with different wellness practitioners across Oakland County who provide tools and resources for health and well-being. And then we provide a lot of printed materials, toolkits to our coalitions who are able to distribute those throughout the county. And then lastly, I wanted to mention quickly, we do have a partnership with Oakland University as well, and this program is focused on mental health. We did a lot of surveys at Oakland University, and mental health rose to the top as being an issue that is a big concern among students, high levels of stress and anxiety. So we do what's called a positive community norms campaign, where we survey students and we try to kind of address the gap between what's actually happening and what people think is happening. And what we found is the majority of students on campus are supportive of people seeking out mental health services when they're having problems. So we create a lot of messaging that we partner with the university to distribute around campus that encourages students to reach out for help, encourages support among students, and tries to address the stigma associated with mental health issues. I think that covers a lot of what we do. If anybody has any questions, I'm happy to answer questions at this point.
Mary Ann, I know we're running a little bit behind, so I'm going to ask if anyone has any questions, if they can put them in the chat and so that she could respond to them. And then also just reminding everyone that we'll be putting resource documents, or already have put them in the chat, so you can contact and reach any of our providers through those links on their website as well. But please feel free to add your questions to the chat, and Mary Ann can respond there. And I think I'm turning it over to Michelle now.
Yes, thank you so much. That was so informative. Thank you so much. Our next speaker, it is my pleasure to introduce Dr. Mikhail. He is Havenwick Hospital's Chief of Staff. He is also our Medical Director of Residential Services. He is also in charge of our Child Adolescent Partial Hospital Program. He is a Wayne State University Clinical Assistant Professor in the Department of Psychiatry. And he is the owner and Child, Adolescent, and Adult Psychiatrist of JC Center for Psychiatric Services. If you're already tired, let me tell you, me too. I don't know how he does all of these things. And then he is also here speaking for us. So thank you so much, Dr. Mikhail, for being here and giving us just a little bit of insight into how you have handled the last 19 months. Thank you so much.
Thank you, Michelle. Hi, everybody. Well, thanks for joining. I actually enjoyed listening to everybody with all the services available through Oakland County. So that's really great. I'm going to try to make it brief. I know we're kind of running behind in time. I don't really have any slide deck, so I'm not going to be presenting. So I'm probably just going to more of a kind of what I present to you, my own observation. And I'm going to really focus mostly on the inpatient setting because that's what they were asking about, our observation in regards to changes since the pandemic in relation to youth suicide. I work mostly in the inpatient unit for children, so that's going to be my focus on. And I think in the beginning, when we first started, I think we had to make big switch with the pandemic going into virtual. I mean, first we had on the unit, we had to do a lot of changes in regards to COVID protocols, making sure that PPEs are available. Of course, working with patients also in regards to using face masks all the time, sanitizing and all those kind of areas, which kind of can be challenging, especially when you're dealing with children and adolescents. So, but I think we did a fairly good job. We didn't have any issues during that time in regards to the safety-wise when it comes to infection rates or anything like that. The other piece that we had to adjust to is basically switching into virtual because we once the pandemic hit, we had to switch. Some physicians wouldn't be able to physically be into the building. So we had to have switch into visual platform and provide all the necessary between hardware and personnel actually to provide for that, which actually allowed us to continue to work at a full capacity during that time, which actually was really needed. Some observations also that we had, or things that we had to change. When you have children coming to the inpatient unit, you have to conduct family meetings with social work. And we're able to switch that into more virtual because we didn't have any visiting, of course, like all the other hospitals available. So we had to have availability of doing family meetings virtually with the parents and the patient. And that actually went fairly well. I think the other challenge that we had is the part of that was a face-to-face interaction. Sometimes that we thought that would be helpful. But of course, because of the limitations, that was not there. But I think overall, I mean, outcomes-wise, I think things turned out to be okay. Now, our also observation that we noticed, and I know you guys had some numbers from Oakland County in regards to ER visits and number of suicide-related visits and all that. And really, for us, we've seen actually a pickup in number of inpatient admissions for mostly during that time, and it had some sort of trend to it, which actually coincides with the pandemic. And part of it was in the beginning we had seen less of admissions. I think everybody was afraid, everybody staying at home and so on. Then in the middle, we started seeing an uptake in the inpatient admission for suicide-related admissions, and things kind of maintained a little bit. And then recently, actually, with school starting, we start seeing an uptick again in that. And I think it's mostly related to increased distress. I think in the beginning was, an anxiety and worry about the virus and the pandemic. Then because of the people being at home and all that, now start seeing kind of, I would say, a lot of added stress between families or whatnot. And then now, as they've been away from school for over a year, and now going back to school, that's adding a lot of stress too. So, and that, like I said, that reflected on what we've seen on the inpatient setting. One of the challenges, I think, and I think you guys probably can touch on that too, is once we have him planned, like moving forward or before discharge, what to plan for aftercare. And it, like you guys probably said, it's kind of more of a mixed blessing because it was virtual, so you can have, you don't have the physical limitation of the patients having access to services or whatnot. But also in the same time, we had a lot of need for mental health, and we had a lot of worries about burnout. And it was burnout either on inpatient setting or for follow-up. And of course, most of you are clinicians, of course, and you know what I'm talking about when it comes down to finding a provider, between therapists, psychiatrists, having appointments ready, and so on. I think the other challenge also is we didn't see not everybody was more keen about the virtual part. I mean, we had patients who would refuse actually to do virtual on discharge. They're asking for the in-person part, We were lucky at Havenwick that we had our partial day program open for in-person all through the pandemic, which actually can help to alleviate some of that, but also for the long term, that was more of a challenge because there is not much of accessibility in regards to in-person compared to virtual. Of course, virtual eliminated, like I said, the distance effect or the availability effect to a certain degree. So that was good. The other challenge I think we faced was because everything is virtual between schooling, between everything. So when you try to at least recommend things, and I think people on the outpatient setting notice that more. Definitely, I see it in my practice. When you try to implement some sort of a structure in a home, especially to access to electronics and so on, it becomes very, very hard because of lack of extracurricular activity that happens. And we've seen that actually even for one of the reasons of inpatient admissions was one of them is basically the kids didn't have much of outlet that either between, how to stress management, how to get energy out, other things and so on. And of course, added reasons that we've seen with the parents being at home sometimes and the uncertainty about what's been going on. So that probably was also the other concern. The other piece, I think, it's that we was noticed, and actually that was actually nationwide. We just had a new a survey that came out, and it actually came out of California because they have a lot of HMOs through Casa Permanente, and they've seen a lot of ER visits for suicide-related symptoms. I know, like I said earlier, it doesn't seem that happened in Oakland County, which is, of course, that's something speak highly of what the effort is being done on the county. But I think nationwide, there's definitely an uptake. I think one of the challenges, I think overall, is kind of I would say long-term sequelae or repercussions of the whole issue was being virtual and so on. Now I know, like you guys said earlier, which is true, and virtual is going to be here to stay. I think it's going to be a lot of work in a way to be able to modify what we can do, especially in a virtual way, to be able to accommodate our youth. One of the best examples I have is issues of privacy. So even if they have access, now do they have privacy during that access to be seen in therapy or so on to address any issues related to suicidality or like mood symptoms or any kind of psychiatric disorders. That's of course added to accessibility. I'm going to end with one more thing actually, which kind of was a recent study that showed that with increased access, there's increased risk. So when you have a lot of access to virtual access, like to internet and whatnot and so on, which added or increased during pandemic, there's definitely an increased risk of mental health disorders. So that kind of puts the balance. I mean, you have the goods and the bads, and that puts it in place. But overall, I think it's definitely was challenging. It definitely, like I said, in an inpatient setting, we're able to accommodate and kind of navigate through it. And definitely was collaboration with all the agencies that you guys talking about, to do more of a prevention, which we're hoping for, so don't have to reach the point that they come into the inpatient. But also, if we have to that point, doing the follow-ups and having all the resources available in either in person or virtual, I think that really definitely helps a lot with our youth and to avoid the whole issues of suicide. I'm going to kind of stop at that, and if you guys have any questions, I'll be more than happy to answer those.
I am not seeing any in the chat. Michelle, did you have any you wanted to ask?
Yes. From your personal experience, Dr. Mikhail, do you think that virtual platforms are really here to stay?
I think they are. I don't think it's gonna totally disappear. It may not be as used as much as it's been used like recently until now. Maybe it's going to be a little bit less, but definitely, it's very, very helpful. It's definitely it has a lot of advantage to it, but I think also there's things that probably need to be addressed along the way. It's like any new, it's not really new, but definitely to be used on that scale, it's totally new. So it's any new thing that, you start jumping and then you start figuring out, okay, the pieces here and there that you need to work on to make it more streamlined with no no issues. But definitely there's, I think, especially privacy issues. I think that's very, very important. When I talk about privacy, I'm not talking about like the VPNs or whatnot. I'm talking about privacy of our patients and having access to. But definitely the access part is huge.
Thank you. We do have one question in the chat. What is the max age considered for adolescents?
It goes up to 18. So 17, once you turn 18, considered adults. That's legal, really. It's not for medical reasons. Legally, that's basically the maximum age. So it's basically up to 17. Once they turn 18, they're considered adults.
And then the final question, have you seen a shift in kind of the average patient that you previously treated as now kind of post-pandemic or during the pandemic? Would you say there has been a change in terms of the patients you are treating and kind of their symptoms?
A change in the presentation, or change in what way?
Change in the themes.
Oh, in the themes.
Mm-hmm.
The most things that we see with that, like I said, I focused mostly because you guys talk about suicide prevention, but the most we've seen was basically suicide related to either depression or mostly anxiety and uncertainty, or basically shift, like I said recently, between being off school and going back into school. But those are kind of, I would say, those are the two major things. Is it changed from before? Definitely, it's kind of very noticeable. Of course, I don't have numbers, so I apologize for that, but definitely it's noticeable.
Thank you so much. Any other questions for Dr. Makayo? Well, thank you so much for your time. I know you are a very busy man, but this has been very insightful into helping us get a better understanding of inpatient services and suicide prevention in the virtual world. So thank you so much, Dr. Makayo, for your time.
Thank you all. You're doing a great job. Thank you so much.
Thank you. All right, I am going to prompt everybody. There's going to be a poll coming up in the chat section. If you can answer that, and then we will move on to our next speaker in just a second. While we're waiting for that, I will introduce our next speaker. Oh, there we go. If everybody could jump on the chat and answer the next poll question. I had to answer it. Pardon me for my delay. We will begin to see some of the answers come up. Okay. So the question was, do you have any experience with suicide, experienced suicidal thoughts, survived a suicide attempt, care for someone who has attempted suicide, or been bereaved by suicide? And it looks like about 83% of the individuals that are on our call today answered yes to that question. And I think that really speaks to suicide and suicide prevention and suicide awareness is a really personal topic. And a lot of us come to these forums, webinars, discussions, presentations to really get a better understanding and to help fight this ongoing battle that as a community we really want to kind of get ahead of. So thank you all for being here. As Kat previously mentioned, this can be a triggering topic. So if anybody needs to step away to take care of themselves, please do so. The rest of us are here to speak with you after the presentation if anybody does need additional support. Erica, Kat, myself, Christine, we are all available as well. So with that being said, I am going to introduce our next speaker, Ms. Gigi Colombini. Gigi is a clinical social worker who since 1990 has focused her passion on working with youth and adults who experience trauma, grief, anxiety, depression, and suicide. Throughout her professional journey, Ms. Colombini has worked and supervised as a crisis counselor, led and facilitated with numerous grief groups, led critical stress incident management, trauma teams, and various community efforts throughout Oakland and Macomb counties. She is currently she can currently be found at the Institute for Hope and Human Flourishing in Bloomfield Hills. So with that, Gigi, I will turn it over to you. Thank you so much for being with us today.
Thank you, Michelle, and thanks everyone for coming. always interesting to hear the statistics. I know so many of the conversations I'm in are around suicide, but even new people that I meet, so many are affected by suicide. It's the conversation that's not being had, but so many people are actually affected by it. So I'm here today to talk about private practice. So the clinic, the Institute for Hope, is in Bloomfield Hills, and it's a individually owned clinic. So some of the things that we encountered as the shift to virtual happened for us. So we didn't have maybe the resources that the larger clinics had, but so we had to, many of us, I'm speaking with other clinic owners, had to scramble and figure out what was okay to do. So, checking with the larger bodies, the APA, the NASW, all those things to see what was okay in terms of shifting everything to telehealth to be able to continue to take care of our patients. And fortunately, they disseminated information really quickly so we could stay pretty much on task and begin to see everyone that needed to be seen. And of course, probably after about 10 days of everything being shut down, I think probably the first 10 days, everybody was like, oh, vacation, yay. And then moved into, oh no, what's really going on with our world? And so then having to adjust everything again, like learning how to get everything HIPAA compliant enough. The insurances shifted to allowing, telehealth, the temporary authorizations, and then not having the deductibles or copays. So then people were really utilizing, mental health services in a big way, which was great on the one hand. And for most clinics that I know, and large and small, we were so overwhelmed and couldn't find, practitioners, clinicians to see the people that needed and wanted to be seen. And so, many of us were encountering those kinds of things in the early stages, and it took a little bit of time to get all of that smoothed out while people were also getting sick in the meantime and, dealing with the real world realities. I know even in my situation, of course, everybody's home. Everyone's home, the kids, the other families, and we're talking about privacy issues. And so for me, it was easier for me to go to my office where nobody was and to see patients virtually there as compared to being at home. But I know a lot of practitioners, trying to find space where they can just simply have enough privacy in their homes while still managing their families and the rest of life. It was pretty daunting in the beginning. I think that we did a pretty amazing job trying to tend to people who are really struggling with things. My clinic specializes in the treatment of suicidality. So I work a lot with suicidal patients or people who've lost loved ones to suicide. Me and my clinicians are all really comfortable and have worked with suicide for a lot of their career. And so there were the higher risk patients in the outpatient setting, right? But we knew that we needed to stay connected to them. So, getting, making sure that we were able to do that was an important part, but finding that, especially getting new referrals, initially there was connection virtually, but it was really hard to keep a good connection, which is so vital when you're talking about really vulnerable issues that lead somebody to be suicidal. So our findings were that it was actually more difficult to, in the long run, keep a great connection, particularly with a young person virtually. So maybe a little bit earlier, I know I got vaccinated in January in the effort to be able to, for the patients that needed it, to be able to go face to face for those again, so that those who were more at risk could be supported in that way. And everybody's trying to, follow some of the guidelines in that. And for the ones that were virtual, I work a lot with youth and having to set good parameters, having to remind them that they can't just wake up 2 minutes before the appointment, sort of sit up in bed, shake their heads and, and start talking like, okay, put a shirt on, the very beginning days were, everybody, all the jokes, everybody was so casual in their work life, right? Going to work in their pajama bottoms and all of that. But also having to have our patients be reminded that they're showing up for an appointment and that we're not just, in somebody's bedroom, having a casual conversation like a friend. So there was all kinds of different things that we encountered that, frankly, we don't encounter when we're, before all of this took place, right? And even the idea, like I started seeing some patients that I met for the first times virtually, and I can remember one situation where a woman came in who'd been struggling with things, and when she walked in my door, she was so tall, and it was like a part that I couldn't get virtually that, had it always been an in-person thing. It would be like, oh, this is a part of her experience, her life experience that would impact things. So, there's different things that in the virtual world we can't always know. I had one woman who, I think it was the beginning of May in 2020, lost her husband to suicide. And she was so completely alone. So she was referred to me, obviously, for the grief, but she really wanted to come in person. So early on, she was seeing no one. She was so isolated. And, the difficulty, right? She was an elder. Elders were not getting together at all. And so she was so alone in her grief process that I actually would see her in person in the early stages because I was the only person she saw in her life in person. And I felt like it was okay. But having to make some of those decisions because I have family and things to consider, right? So for all of us, we're trying to be supportive for the higher needs of our caseloads and also remember that we're human and we're taking care of ourselves and our families. I know that we struggled with keeping younger kids. I see a number of younger kids, but keeping them engaged virtually for me was really challenging, particularly for a whole session, maybe for 15, 20 minutes, but then it was very difficult because I'm used to, using games or some different things. And as a smaller clinic without be able to do a big investment in some of the virtual options out there. So for many of the individual practitioners, I would imagine they encountered the same things. I mean, I know that there became, access to things that you could do virtually with people, but that would become a lot of financial investment, which isn't easy. And then things exploded in terms of the numbers. So I have several companies that reached out, whether it was for trainings for their HR staffs because they had so many of their people were in crisis and how to manage that because that's a part of the work that we do is we do training for crisis intervention. But the one bonus is we could do all these trainings virtually, so we could really do a lot of people at once. But so finding times to do trainings and schools and parent groups and so many groups affected. So moving to a virtual platform had actually a lot of benefits in that way. So I did a lot of training in larger group numbers at once and was hearing some good feedback because I still hear like, oh yeah, we saw that, parent group training and that's how we got connected to you. And it was really helpful. So the virtual platform has a lot of benefit in even in this way, being able to reach out to all of you. But I think there are ways that being able to be more face-to-face, I know that there's a lot of clinics that most of their clinicians are still completely virtual. And I think with the populations that I work with, it's just a bit tougher to maintain a lot of growth and working on what's going on with our people if it's consistently virtual. Sometimes injecting a face-to-face now and then can be really helpful. So if clinicians are able to do that, it's also difficult when even still, I was working with a kid last week, and I noticed like the shadow behind their bedroom door. They had like a sort of a glass thing on their door, and I'm like, I think your parent is listening in on the conversation, which is not okay. Like, you know, if there's privacy issues and things like that. So we're still encountering those things. Like, how do we best support our people with all of these variables that we have to encounter now that we're doing things virtually? Just seeing if I have anything else. We've also had many large companies reach out to, you know, that have given us, that we are receiving direct referrals from. And the other big piece is, of course, hiring clinicians. I think probably everybody out there has had such a difficult time finding clinicians because we're all so really, really busy. And it's hard. It's hard in the long to keep this, the long run going to, you know, anything that we do over an intense period of time becomes very stressful and sometimes even leads to a crisis. Even if we're holding, you know, our coffee cup in our hand for 10 minutes, we got to put it down, hold it for 20 minutes, and it's the only thing that we're focusing on because we've been doing it for such a long period of time. You know, when we're holding it for 3 days, it feels like we're not going to be able to function anymore. You know, in this sort of all the unknowns of all of this, in terms of COVID and everything, and how long it's going to go on for, and how long will our practitioners need to be working in this way, and are the numbers going up, are the numbers going down? I was sick this week, got another COVID test, even though I'm vaccinated, all the unknowns. It's difficult not only for our patients, but certainly for those of us in the field trying to help others. So remembering our own self-care as much as we can is an important piece too. So thank you very much.
Thank you so much, Gigi. I think we all appreciate your very knowledgeable insight. If you have any questions, feel free to put them in the chat. I do have one that I'd like to start with. What has really helped your clients most through the grieving process and kind of gain mental wellness during this virtual time? How have you been able to really, what have you seen that's helped in your abilities to really connect with them?
There's definitely been, we're definitely seeing we're seeing more suicides, but the overdoses rates and that, has definitely more grief work out there right now. Normalizing the grief reactions, sitting down and talking, particularly when it comes to suicide grief, reinforcing the need to be able to talk with family members about it, check in on each other, because so much with suicide, when we've had a suicide loss, is this fear of who else is suicidal and that we don't know. And so encouraging families to talk together. So because again, we're in these pods, it's insular since COVID, so we're maybe not reaching out as much. I think that the support groups are now, some of them going back to somewhat in person, but they were virtual, which was helpful. But the idea that we check in on our families, normalizing all the grief responses, has been a really helpful thing. And even now they'll come back a couple months later and it's like, oh yeah, we do have to talk to each other about these things. We do have to remember that it's really okay to be discussing suicide directly with each other. So those reminders really help families get through difficult times when they're isolated from many of the things that often help them.
Excellent. Thank you so much. One more question. How do you ensure safety for clients with thoughts of suicide while seeing them virtually?
So, a couple of things doing, talking about means reduction, safety in the home, some of the things that in the very beginning you guys talked about that Oakland County's done some trainings on, but that's always an important piece. There's a couple of big things that if I'm concerned about somebody suicidal, I'm making sure to have a means safety conversation, firearms in the home or other things that, they might be choosing to use in a plan for suicide. But then also creating a safety plan with them. And there's Brown and Stanley created a model. There's a model that we use that's on our website that's really super user-friendly, easy. But so we developed that like in our first session to make sure that they've got something to help them think about. But I also refer back to it if they're having, reporting having had thoughts of suicide in between. Then we talk about, well, did you check, did you use your safety plan? Did you remember to take a look at it when you were feeling suicidal? Things like that, so that they've got something that can help them in the moments of distress in between sessions. Those are a couple of big evidence-based things that are helpful.
Thank you so much. One more question. How do you support a senior that looks healthy but has had thoughts of suicide because he has received a diagnosis from his doctor that he has a debilitating disease?
Yeah, those are so difficult. Since the elder males are the ones who die by suicide the most in terms of rates of suicide, right? And the impacts, though, like the woman I referred to, her husband had a similar situation where he was medically compromised. But the impacts of his death by suicide far outweighed just the idea that it was likely that he was dying not so long after that. He was in his early 90s and that kind of a thing. So sometimes talking with them about how it does impact the family, even though we can empathize with how painful and how difficult it must be to, know that their body's, slowing down, changing, that they're in a dying process. So talking about all those feelings, but also talking about the impacts of a suicide death on their family. Excuse me.
Thank you so much. All right. Well, thank you, Gigi, so much for being here. I know you are recovering from sickness, but you did a wonderful job and you look beautiful. So thank you so much.
Thank you.
All right. We are going to shift gears. If everybody can go back to their chat box, we're going to add another poll question. Hopefully it will be up in just a second. Okay, here we go. The next poll question. How are you feeling about virtual events and meetings right now? Love to hear from everybody and how they're doing. All right, we've got some answers coming in. All right, so it looks like the options were love them, keep them coming. There are some benefits, and I never want to Zoom again. It looks like we are about 50%. There are some benefits. So I think, speaking personally, there are some huge benefits in terms of being able to reach large audiences and people that do have barriers like transportation, childcare issues. They can't leave their office for a long period of time, but can certainly hop onto a 1-hour Zoom meeting. So there's been a lot of opportunity for additional education and growth throughout this platform. And it looks like everybody's kind of consistent with that. We have 44% of people said, love them, keep them coming. So I think we are going to move into like a hybrid world of having both options. So thank you everybody for your responses. With that, I am going to move on to our next speaker, Susan Benson, who is the Director of Specialized Student Support at Oakland Schools and has been for the past 23 years. In addition to being an integral member of the task force and partner of our organization. She is also a suicide prevention trainer, and she is going to speak on how school services have really adjusted and adapted to mental health needs of students virtually. So please welcome Susan Benson.
Hi, everyone, and thanks so much, Michelle. First of all, I want to mention that about 15 minutes ago, what must be 75 roofers just showed up and placed themselves on top of our building. So there is no way I can mute out the noise and extreme racket and pounding that they are insistent upon creating for me up there. So I apologize. You're going to hear some roofing going on. But thanks for hanging in there. And as we were saying, Zoom meetings, gotta love them. So it has certainly been a really challenging time for schools during the pandemic, to say the least. First and foremost, I think we have to talk about the culture shift. And as Michelle mentioned, I've been here for a long time, for well over 20 years. And I remember saying to our previous superintendent that, you know, we are in the mental health business. And she said, no, we're not. We are in the education business, and we're not going to agree on this, Susan. And over the course of the last 6-7 years of her tenure here at Oakland Schools, she and I kept going back and forth. We're in the mental health business. No, we're not. We're in the education business. It was at her retirement luncheon several years ago. She took me aside and said, okay, I admit we're in the mental health business. Thank you. But it's been a long uphill battle to get educators to make sure that we are understanding that we are in the mental health business. And that's a huge culture shift. So while we're not in the traditional role of service provider, we have been consistently and very intentionally expanding our focus of making sure that staff and students have a wealth of resources that we have made available to them that can help safeguard their mental health. And we say staff and students, and let's talk about staff first. We certainly can go back and look at that old analogy of making sure you put your own oxygen mask on first if you lose altitude during an emergency in the air. And we have to make certain that we're doing that same thing at schools. We want to make sure that the helpers are equipped and ready to help students. But we talk about the culture shift, you think about your average middle school social studies teacher, and they are extremely well trained in what they do, but what they do and what they have done is not mental health training. So we are making sure that staff are trained, all staff are trained in trauma recognition. And we're training teachers, certainly, but we're also training front office staff. We're training lunchroom staff, bus drivers, crossing guards, security officers. Very interesting fact, by the way, when I mentioned security officers, in whatever capacity, in whatever district, we consistently hear that students form trusting and important relationships with those security officers. So we're making sure that we get our security officers trained. Of course, our parapros and our administrators, our coaches. For some reason, coaches are often overlooked. And just a very quick story, both of my kids who are grown were both debate coaches in high school and for high schools. Even when they were in college and after college, they were both high school debate coaches. Up until the pandemic, they would spend almost every weekend on the road with a group of students, high school students in different states in competition for debate. And the amount of times that my kids ended up talking to students who who confided in them that they were struggling with their mental health was astounding. So, of course, being my kids, they were very familiar with the information about suicide, about how to get help, about it. Actually, they're both assist trained, big surprise there. And they were able to offer good, solid, strong help. And they also knew to talk to me to make sure that they had given out the right resources. But that just goes to underscore how important it is to make sure that we're reaching deeply into the schools to train all staff. So that is something that we're being very, as I say, very intentional about. And we train students. This is something relatively new for us, but we know that it's vital to make sure that our school social workers, our school psychologists, our school counselors are ready and up to date with their training to help students, but we can't rely on them. We have to also rely on students to help each other and to get their peers to the right people. Circling back to our school social workers, counselors, and psychologists, we couldn't run without them, and they are amazing. But many of them have said, I'm the person who students seek out when they don't need a third period English and they need to trade it with a fifth period math. That's what I do. I am not up to date in best practices on school suicide or student suicide. So we have to make sure that we are providing that training and that we're not taking for granted, that we're not assuming that just because someone is a school counselor or a school social worker or a school psychologist, that they're ready and willing and able to provide what students need. Oftentimes, when we have had student suicides in districts, we've had to look to neighboring districts to come in and provide some help. We had a number of student suicides a couple years ago in a smaller district, and the district only had, at the time, one social worker that covered a number of buildings. And I was on the phone with her the morning we learned of the student's death, and she said, Susan, I can't do it. I've known this family. I can't do it. And we talked about it for a minute, and then it came out that she had also lost a sibling to suicide the year before. She was in no shape to provide the assistance that she needed, the support that she needed to be able to offer to the community. So we were able to tap into other districts to help. Ideally, though, we want districts and buildings to be able to support their own students, because we want to be able for students to know that the people that they needed on Tuesday will also be there on Friday and next month when they feel ready to talk about their own issues. So that's why we have such an emphasis on training in the district level, and it's so many different layers. We are training students and staff in youth mental health first aid, suicide prevention assist, safe talk, intervention post-vention. We also train in trauma identification, okay to say, here for you. We make sure there are teams at the building levels and that they're ready and able to respond to any kind of crisis, and that we are looking at staff turnover. We, as everyone knows, we're severely understaffed in schools. There's a shortage at every level. So making sure that when people who are trained leave, we are training the next people who are coming in to replace those positions. But adaptations have been ever changing by their very nature, and to ask teachers and school personnel to undertake something that they just don't feel ready to do is something that we keep looking at with a kind of gentle pressure, relentlessly applied approach. And we know that student suicides have decreased over the past period of months over the pandemic. There's a lot of reasons for that. This isn't something that's just specific to Oakland County, but there's a lot of reasons. Many reasons come to mind, but include there's a shift in students not being physically in the building. That is a huge shift for a lot of kids. It's very welcome for many. It's terrifying for others. Gigi talked about the privacy of students being lost in therapy. And for many kids, having teachers not have eyes on those students directly has been opportunity to just flick off the camera and go missing. And teachers talk about how incredibly difficult it is to connect to those students. Reported bullying was down, but you can, of course, there's always instances of cyberbullying, and we certainly would never, even in a million years, say it didn't exist. But for a lot of kids, some of the pressure was off, not having to go to school. And administrators, counselors, school staff in general need to take a look at that and how we are responding as a community to data that supports a decrease in harm when students don't have to be physically present in class all the time. And what that means at so many different levels. Many students reported feeling like they saw a decrease in their own stress, and they felt like they were less isolated. Because we were all isolated to some degree, there was some comfort. Many students have said, and we have done a little bit of polling on this quite a bit. We'd like to do a lot more. But again, the difference was that everyone was feeling isolated, but they didn't feel so alone in their struggle to fit in, because everyone was kind of experiencing the same things. Being not connected to students was the first and foremost complaint that we heard from teachers. They said over and again, I just didn't have eyes on my kids, and it felt really out of control because I wasn't able to say, hey, Susan, can you stay after class? I'd like to talk to you for a minute. I'm a little concerned. I've noticed a change. I've noticed this. It's really hard to do that when children, adults, we all flip off our cameras sometimes, and it's really hard for teachers. So again, the privacy issue is huge. It's also a huge issue for teachers. It's really, again, it's very, very difficult for instructors to have their cameras on and show their private lives to students. And there's been an enormous increase in teachers asking for mental health support because of the stress that they feel, not only to manage everything that they have to manage, but also to show their weaknesses in ways they've never had to before. And that's very difficult. So I think what it's taught us, what it's reinforced for us, is that schools have to reach students in a variety of ways. And we've worked really hard to keep a spotlight on responding to and expanding ways for staff and students to connect with other people, with people who are trained, with people who are ready to listen and to help. And yes, we've certainly spent an unprecedented amount of money on those supports programs that are vital to helping kids and staff. But as members of the task force, we firmly believe that we need to partner with other agencies and draw from their expertise. So we've talked about OCHN and core providers and all of the many mental health agencies. We couldn't do it without them. We know schools will be forever in the mental health business. And we embrace the model of community, and we embrace the model of partnership with those very community partners who established their expertise in the field. But lastly, one of the positive components is what we want to embed in our school culture, along with inclusion, along with compassion, along with support. We want to really, above all else, make sure that students, that staff are willing to ask for help. And we know that when we talk to students, making sure that we embrace a culture of acceptance around asking for help is one of the best ways we can help keep students safe. Any questions?
We do have one question.
Okay.
For you. Thank you so much for that wonderful insight. One question is, lots of parents are really concerned about learning gaps, adjustments to emotional issues in terms of returning to school. What do you suggest to them?
You know, one of the things I think that we just can't stress enough is that they take the opportunity to talk specifically with their kids' teachers about how their child has responded, how their child is coming back. Sometimes teachers talk about parents who absolutely, with all good intent, talk about the learning gap as it applies to the country or the world and the year that we've lost now, well, more than a year, but helping look specifically at the strengths of their student. What we're asking teachers to do is help really put in place an individualized plan for the best way for their students to learn. I think Gigi hit on it earlier that, you know, it's different for every person. It's different for every student. We've also seen a tremendous amount of students who've absolutely flourished in virtual learning environments. Their grades got better, their attendance got better, they became stronger. So we have to look at what works for each individual student. Any other questions?
No, Susan, I have to say you were so thorough and enjoyed everything just tremendously.
Thank you so much, and thanks for having me.
Absolutely. So Kat had introduced me. I'm just popping in right now. I'm Erica Sam. I am a member of the task force, also with Farmington Public Schools, social worker in the field. And we really sincerely want to thank you for attending everyone today's community discussion. We really wanted it to be just that, a discussion. And so thank you to our speakers who came on and shared their wealth of knowledge, information on resources in the community, and just nuggets of what we've all been experiencing and just needed to shed light on. There are, I think, a couple questions still in the chat. So what we'll do is go ahead and send those out to some of our speakers and get some answers. And we'll make sure everyone who was registered gets answers to those questions. So we want to just make sure you know that. And as you saw in the chat as well, we'll send out the slides to make that available. We also want to share with you that in addition to today's event, we will be offering a virtual Suicide Prevention 101, and that will take place on Thursday, October 28th from 7 to 8:30. Everyone is welcome to attend. The Suicide Prevention 101 training is a research-informed presentation that has been created by the task force to teach people how to recognize signs of suicide, what they can do about it, and we'll make sure to put some information in the chat on how you could register for that. Also, just want to make sure that you know that the Oakland County Suicide Prevention Task Force meets every other month and works on suicide prevention efforts for initiatives throughout Oakland County. Anyone and everyone is welcome to attend and participate. The more voices that we have, the better able we can truly have a suicide safer community. If you're interested in participating and joining our meetings and being on the list, please email Kat. She's also going to add her email into the chat right now. It has been shared, and she'll make sure that you get on our mailing list for the meeting invites and things. The task force also does have a website where you can find additional information about suicide prevention and resources throughout Oakland County. We're going to be putting that web address in the chat. The chat's going to be very active right now with lots of tidbits for you. But that site is oaklandgov.com/suicide prevention. And I see some people saying they don't have access. We'll look into all of that for you. So we want to make sure that you have that. So lots of opportunities If you want to keep the conversation going and being a part of suicide prevention efforts, which, you know, I've seen a couple of things say that everyone assumes suicide prevention is really just a phone number, right? The suicide lifeline, but it is so much more. And I think that you could see that in today's conversation, that there are many layers and efforts about really upstream approaches and direct service and crisis interventions of how we can all play a part. We would like to ask that you answer a few poll questions before you hop off. So if you could spend just a couple more seconds with us. Oh, Tanya, so the links aren't working. We'll make sure that you get those back out then. We'll make sure that we send those out if they're not accessing right now. But we have a couple poll questions that we would just love to get your input on. The first one is, have you or a loved one receive virtual mental health services? Yes, no, or prefer not to say. If you just have a moment to just go ahead and do that for us, be great. I'm gonna get my answer in. Yeah. Yep. So much like we've seen in our conversations, virtual services for mental health are very popular right now. We can see where there are some benefits, still challenges, but challenges with any type of service. But overwhelmingly, 60% of us have had either a loved one or us have received services. So thank you for sharing that. That kind of confirms just that we're all in need of that support. And then a couple questions that we just wanted to ask real quick in the poll. The next one is going to be more about today's event. And that should be popping up. So the first one is, this event improved my awareness of resources within Oakland County of where to go for help. And if you could indicate that on a strongly agree, disagree, strongly disagree, or you're unsure, go ahead and submit that too. That would be fantastic for us. All right. All right. So a majority are either strongly agreeing or agreeing. So really happy to hear that could be part of what is your takeaway, is just an understanding of resources that are available to you for yourself, for your loved ones, for your community neighbors. Just it's good to know what's aware. There is a lot, but it can be confusing to navigate. And so we're happy that you can take that away with you. And then one last question. This event, about this event will be popping up. I'll just do one more real quick. And it is, this event improved my knowledge on how to help a peer or a loved one. So if you could give us some feedback on that, we really would appreciate it. Okay. All right. Definitely seeing this chat going, and the poll is coming in. And again, it is nice to see that a lot of you did find it meaningful, that information. So majority, a lot had the agree or strongly agree. So we do appreciate that. And otherwise, fantastic. Thank you so much for that feedback. And again, we hope that you found it meaningful. And I want to do a special shout out to some of the other people that didn't get formal recognition. I want to give a shout out to Suzanne Weinert, who was the behind the scenes. So she's been helping us put up the polls, move the slides, and do some of that great work. So Suzanne, we couldn't have done it without you, so thank you. And then to my fellow leadership board members, Christine, Michelle, and Kat, you guys are fabulous. Thank you so much for all of your efforts. We will go through the chat to check out any links that we need to send out, answer any of those additional questions, and follow up with you. So enjoy the rest of your day, and thank you so much for spending your morning with us.
Thank you so much.